My name is Dr. Stephanie Burdick. I am a physician. I am an adult hospitalist. So essentially I take care of hospitalized adult patients only. I don't see patients in the clinic, just really the sickest patients who are in the hospital. And I sort of do that as my day job half the time. And the other half of the time, I am our medical director for clinical pathways at a large tertiary care center in Grand Rapids, Michigan called Spectrum Health. And I work with multidisciplinary teams to implement evidence-based practice on the front lines to really drive quality improvement outcomes for our patients. So I'm thrilled to be here tonight. We have an awesome panel. We have Dr. Kristen Olwell, who is a senior occupational therapist. We have Karen Strenger, who is a physician assistant in transplant hepatology. Professor Beth Peshkin, who is a licensed genetic counselor, professor of oncology, and director of genetic counseling at Georgetown Comprehensive Cancer Center. And then we have Dr. Keene Saavedra, who is a pharmacist, amongst many other professional interests and qualifications. So I'm just going to introduce them all to you and start with Kristen. Can you tell us just a little bit about yourself? Tell us sort of what your work is like and how you sort of got to the role that you're in today.
Of course. Well, hi, everybody. I'm Kristen. And as she mentioned, I am a senior occupational therapist at NYU Langone Orthopedic Hospital. I am in their pediatric outpatient department. So I see children birth to 21 years old. Our day-to-day is anywhere from 6 to 10 patients a day for about 45-minute therapy sessions. And we see a really wide variety of diagnoses. In addition to providing, clinical patient care, I also oversee an infant aquatic therapy program. I conduct clinical research, mentor new staff, as well as students. And I also have specific areas that I am a little more specialized within pediatric. So that includes things such as brachial plexus injuries, complex cardiac conditions in infants, as well as neuromuscular disorders. I am also part of a NICU follow-up team where I evaluate and screen infants who were recently discharged from the NICU. Additionally, I have some advanced certifications in various treatment approaches. So I do also provide aquatic-based occupational therapy, not just land-based therapy, and then administer certain assessments and scoring. So just a little background, I graduated from Georgetown with a bachelor's of science in human science, and then I had a minor in psychology. I then went on to Boston University, where I received a master's of science degree in OT, and then decided I kind of wanted to continue my education and did a post-professional doctorate in occupational therapy as well.
Fantastic. And so how did you kind of know how kind of did you go down this winding road? I think we have a lot of probably human science majors on the call, and a lot of us were also human science majors. And how did you know that you wanted to do occupational therapy? Like, what experiences do you have that really led you there?
Yeah, so I think the biggest one is I come from a parent who was an occupational therapist as well. So I always knew I wanted to be in a somewhat medical field, but wasn't sure if I wanted to be a doctor, wasn't sure if I wanted to go down PA, nurse practitioner, or therapy. And I started just doing a lot of volunteering and doing a lot of observing OTs, observing PTs, and I just kind of fell in love with it. And, as OTs, I know a lot of people might not be even familiar with what our role is. We help people across the lifespan, whether that's a NICU baby or, an elderly care, someone at the end stage of their life. We help people be able to do all the things that they need to be able to do on a day-to-day basis or want to be able to do on a day-to-day basis. So that's everything from being able to get dressed to, cook a simple meal. For infants, that's, play and environmental exploration. And so that's kind of what got me excited about it and sort of how I learned about it. I had exposure pretty early on. And it's part of the reason why I chose to do a human science major, because a lot of the prerequisites, which I'm happy to also talk about later on, were really well aligned with what the human science program offered, as well as having the psychology minor.
Fantastic. So Karen, can you tell us a little bit about your role and what your day-to-day is like and sort of how you got to the position you are in transplant hepatology?
Sure. My name is Karen Strenger. I'm a physician assistant working in liver transplant at the MedStar Georgetown Transplant Institute. I've been here about 5 years, and I've been a physician assistant for about 10 years now in total. My job is super cool and I love it. I treat patients with end-stage liver disease who are admitted to the hospital, so they're usually pretty sick. I help evaluate them and get them listed for transplant. I educate patients and their families. I, treat patients. I round on them in the hospital every day, provide comprehensive medical care, order lab tests and diagnostics and, studies and medications. And I perform procedures on patients. I work very closely with our medical residents and fellows and attendings to just really provide outstanding care for these super sick and complicated patients. So it's fascinating and super, super rewarding work. And, every day is different. And I learn something new every day too, which is something else I love about what I do. Just to give you a little background, I graduated from Emory University back in 2010 with a bachelor's of science in biological anthropology. I knew I wanted to do something in the medical field. So I did all the typical pre-med requirements that you would need. And I actually worked full-time as an EMT while I was in college. That was just a passion of mine. And I acquired probably thousands of hours of clinical experience through doing that. And I had a lot of time to talk to physicians and PAs and nurse practitioners and nurses and, the whole spectrum of healthcare providers. And, after spending a lot of time with all of them, I felt like a physician assistant was really a natural and great fit for me. And honestly, it's the best decision that I ever could have made. So I'm very happy. I didn't want to be in school for a really, really long time, 4 years of college and then 4 years of medical school and 3 years of residency and 3+ years of fellowship. That's like almost 14 or 15 years of training. And I kind of just really wanted to dive right in. So for me, this was really a natural fit. So right after college, I went to the physician assistant program at the George Washington University. I graduated from there in 2012, and I actually started off working in emergency medicine, which was also a really natural fit for me, just given my history of background as an EMT. And I thought it was super interesting and super cool. And then, after a couple of years, I decided I wanted to do something different. And that's kind of how I transitioned into the role that I'm in now. And one of the other things I love about being a PA is just that I'm basically trained a little bit in every specialty. So I have the opportunity to kind of switch around and do different things throughout my career to learn a lot and really expand my background.
So Karen, I love transplant and I love hepatology too, as someone who takes care of really sick hospitalized adults. I can definitely very much appreciate your skill set. How did you end up? Transplant hepatology is a very specialized field with very sick patients. So I think two things I'm super interested in is one, how did you kind of end up in transplant hepatology? And then two, I think it would be really helpful for students to understand how independently physician assistants can very much practice sort of on a day-to-day basis. All the things that you do sort of in a day and what that kind of looks like to them.
Okay. So I fell into it kind of by accident. I knew I was looking for something different. And one of my colleagues who I actually trained with in school was working outpatient in the liver transplant clinic and said, "Hey, we're looking to hire more people inpatient. And, this might be something that you're interested in. You should come in and interview with us and meet everyone." And it was a really natural fit for me. And I learned a lot on the job because transplant is very, complex medicine. And again, most of our patients with end-stage liver disease are critically ill. A lot of them are in the ICU. So I had to pick up a lot on the job, but it's really honestly been fascinating. In terms of how the second part of your question was how independently do I function? Because our patients are so sick and complicated, I work very closely with the entire team. I mean, I certainly have the ability to see patients independently, diagnose and treat. And often for our PAs and nurse practitioners that are working outpatient in the clinics, that's kind of more typical of how they will function. Inpatient, I certainly do see my own patients. I also see patients with the residents and the fellows. Some of the patients are primarily on our service. Some of the patients we are consulting on because they're being primarily managed by the ICU team. But because I've been doing transplant specifically for a long time, I really do a lot of teaching with the residents and the fellows. Like I teach them how to do certain procedures like paracentesis, where we drain fluid off of the abdomen of our patients with liver failure. That's something that I really teach everybody how to do. So I do some teaching about transplant in general for all the people on our team. And we just function very, very closely together. It's very collegial. I work very closely with all the surgeons and the liver specialists. And day to day, my role varies so much. It's hard to really give you like a definitive concrete example because it's changing all the time.
And I think that's one of the great parts of being in medicine is you really like every day is sort of a new adventure, right? And I think your role is very much like that, where, you never really know exactly what your day is going to be like. You have a general idea, but sort of anything can happen and it keeps it interesting. So thank you. So Beth, what about you? How did you kind of get to your current position? What was the path that brought you there? And sort of what is your current day-to-day work look like?
Well, thank you. First of all, let me thank the organizers and the students for joining us tonight. It's a pleasure to be here. I think like many people on the panel, one of the things that I love about my job is that I'm not doing the same thing every day. And I think that's one of the great things about practicing in an academic medical center. So just by virtue of the different titles that I hold, I think is reflective of all the different activities that I do. So my work spans clinical work as the director of cancer genetic counseling at our cancer center here, where I work with a team of a few genetic counselors as well as a medical oncologist. And then we also interact with a whole care team of surgeons, radiation oncologists, social workers, et cetera, and a number of other specialists. So my primary area of expertise is in oncology. I also do some clinical and research work in pharmacogenomics, which is looking at how genetic testing may impact medication dose or choice of medication. But most of my work is with hereditary cancer families in the clinic. And then also I am also involved in at least 5 different research projects looking at outcomes and service delivery issues in genetic counseling and testing. And I'm the education director for an endowed center here called the Fisher Center for Hereditary Cancer and Clinical Cancer Genomics. And then I also do I love everything that I do, but probably the thing I love the most is I teach courses of my own in the undergraduate and graduate campuses in disability, genomics, precision medicine, ethics, and policy. So really they're addressing the spectrum of issues in genomics. I actually feel very fortunate because I knew what I wanted to be when I was about 12 years old. Being the nerdy child that I was at the time, I watched a documentary about the quote unquote elephant man, Joseph Merrick. And at the end, I subscribed to the mailing list for the Neurofibromatosis Foundation, and they were holding a conference in Baltimore, which is where I'm from. And I asked my dad, who was in healthcare policy, if he would take me to the conference. And there we heard a genetic counselor on a panel speak. And I was like, well, that's really cool. She's whip smart and also provides so much support to these families. I think that's what I would want to do, because like Karen said, even then I knew that I didn't think I wanted to be in school for 14 years. I was eager to get out in the work world. But the most memorable thing about that conference was that, you know, if you've heard anything about Joseph Merrick or the elephant man, which I know is not a good term, but that's what he was called at the time in the 1800s. My conception of people with NF was with somebody who had large tumors and who had various other problems. And one of the things that we learned at this meeting was that people can have very subtle signs of NF and you would never know it. And I remember during one of the breaks at the conference, a mom of a son with NF came up to me and she leaned into me and she said, I was about 12 years old. And she said, "Are you here because you have NF?" And I remember the weight of my father's hand on my shoulder saying, "Well, she does not, but we are here to learn more about and support the foundation." And then he took me aside afterwards and said, "So we learned today that you can't always tell that people have certain conditions by looking at them." So it was a very nice moment. So I carried that forward in my undergrad world. I graduated from University of Maryland with a degree in microbiology, which I chose because I liked actually the public health aspect of that. And then have a master's degree, which is the terminal degree in my field, master's of an MS degree in medical genetics from the University of Wisconsin in Madison. And then I have a certificate of bioethics and health policy from Loyola University.
So Beth, I think that's an incredible story. First of all, thank you so much for sharing that. That's so wonderful to hear. What a amazing story for what's inspired you. And I can see how it would continue to drive you forward in your work. I think I just remember when I was a student back at Georgetown in human science and hearing about what people did, I always felt I never really understand what is how do you get there in terms of what does your day look like? Are you in clinic today and then tomorrow you're working on teaching class and then the day after that you're seeing, you're back in clinic? What does your day-to-day look like?
So at this point in my career, I don't see clinical patients anymore because I don't have the time to dedicate to that. But I oversee all of the clinical cases in my role as director. For the genetic counselors who are in clinic, generally they devote most of their time to clinic and clinic-related activities and also participate in some of our research programs. So genetic counselors in general can have, particularly those that are not affiliated with academic medical centers, may spend 100% of their time seeing patients, which can be a lot, And then other genetic counselors have really no contact with the clinical world and also do entirely research. And this may be surprising to a lot of people, but some of the largest employers of genetic counselors nowadays are laboratories. So genetic counselors are involved in writing reports or reclassifying, doing literature searches and database searches to classify genomic variants. So there really are a variety of settings for genetic counselors to practice in. I'd say the two biggest specialties probably now are oncology and prenatal genetics for those who are practicing clinically.
That's fascinating. Thank you. I do want to move on to Keene, who is our pharmacist. So I have a brother who is a pharmacist. I have a soft spot in my heart for pharmacists in the hospital. They are some of the most helpful people that I think are such an untapped resource in so many ways, so knowledgeable and so helpful. And I see Karen nodding her head too, because I can imagine in the transplant world, there's a whole specialty of transplant pharmacy and preventing patients' organs from getting rejected. Again, pharmacists just have such a broad role in our clinical team. So if you could just sort of tell us about your role, how you decided you wanted to become a pharmacist, what your training was like, and a little bit about what you do now.
So hi, everyone. I'm Dr. Keene Saavedra. I was a clinical pharmacist, and now I recently became an academic detailer. I actually also recently started my own small business, Mango Sage LLC, December 2021. And my first client is Alosa Health, where I am doing academic detailing. And for those who don't know what academic detailing is, I basically talk to primary care providers in Virginia and educate them on evidence-based management of pain and opioid use disorder. And I started this role in February 2022, so I'm still figuring out the ins and outs of this role. But prior to academic detailing, I was a clinical pharmacist in a 300-bed hospital, and I'm board certified in pharmacotherapy, infectious diseases, and HIV pharmacy. I graduated in 2012 with a BS in human science from the NHS and a PharmD, which is a doctorate, in 2016 from the Medical University of South Carolina. And I worked in Brooklyn, New York as a resident in 2016. and as a clinical pharmacist in Myrtle Beach, South Carolina from 2017 to January 2022. And really like my day-to-day when I was a clinical pharmacist, I would work up the patients in the morning. So just to back up, when you're a pharmacist in the hospital, you can either work more like in a dispensing role, like in the central pharmacy, or on the floor. And I was more on the floor. And what I did was in the morning, I would go to either ICU or like med surg floors. I would look at, the patients for the day. Then I would attend rounds. And these were big interprofessional rounds. They had PAs, they had, the doctors, they had the nurses, they had respiratory therapy, they had nutrition, they had case management. And, I would look at patients like renal function, any drug-drug interactions, like med cost issues, microbiology. And I know like some pharmacists do this. They actually look at the pharmacogenomics, but I didn't do that in my work. And I would just make the interventions and rounds. And after rounds, I would just make sure that interventions actually got carried out. And I would like talk to the, PAs, or also help like with the nurses if they needed to get meds, or answer any drug information requests. So it's a lot of things. And what I said, it sounds a lot, but that's not even like covering like the surface. And then I guess, how did I get into pharmacy? So actually, as a lot of human science, majors probably can relate, I wanted to be a physician. But then when I was like stopping to think about it, I was like, do I want to become a physician because I really want to, or is it because my parents wanted me to? And I did realize I wanted to help people, but after doing more research on the lifestyle of a physician, I was like, I really don't want to waste the prime years of my life working long hours for minimal pay as a resident, and then having like a bad work-life balance, like when you do start making good pay, depending on like what specialty. And I thought clinical pharmacy was just a really good balance because you still get to be heavily involved in patient care. You get good pay after 4 to 6 years rather than like 7 to like 14 years. And you just also have just good work-life balance overall. And I just really like the interprofessional aspect. And, I was just really surprised of like what like pharmacists can do, like as I was like learning in pharmacy school.
And so you said you've started a business. Tell us a little bit about that, and sort of what you do with your business, and sort of how you decided you wanted to be sort of in that world and addressing opiate use disorder, and how you interact with primary care physicians. I'd love to hear more about that.
Sure. So I really love clinical pharmacy, and I think it was just like time for a change. Like I experienced like burnout in my career, like especially like during residency, because that was really tough because we did like 24-hour on call, and that like really got me. Like I would stay at the hospital like overnight with the physicians and like go to codes and all that stuff. And it was better at my current job, or my former job, but I still feel like I'd noticed that I wasn't like kind of being like my more like optimistic self. So I kind of want to do a change where I can help people, and I'm like, I want to be my own boss. So actually it was through like a contact at Georgetown, because I was with an organization called PharmD, where we had to do like our like the internship your senior year. And it was an organization called PharmD. It's a Georgetown University Medical Center program that looks at how the pharmaceutical industry markets drugs and how it impacts patient care. And through that, I learned about academic detailing. And through that, I made a contact, because my mentor from the internship, I still like talk to her like this day, and she helped me get the job. And basically what we do is we go into the clinic and really like try to talk to the primary care providers, and just like really just say like, hey, we're a resource. Here's what you can do for acute pain, chronic pain, opioid use disorder, and really like try to tell them like, actually opioids are really not that great. Here are the options. Here's the literature behind it. And like, we really have a really good point of care references like that are easy for the prescriber, so they know what to do instead of an opioid.
That's awesome. So it sounds like you had really recognized the part of your job that you love, and tried to sort of narrow in on that, which is amazing. And I think that brings up a great point. Many of us have really busy careers, and burnout is a really big thing. I think, regardless of what path you take sort of in the medical field, it's rigorous in a different way, in one way or another, and can be stressful, and it can lead to burnout. And I think one of the things that we're realizing in medicine coming out of COVID, where we have a lot of burned out clinicians in many different ways, are from our physician's assistants to our therapists, to our bedside nurses, to our care managers, to our doctors, is really trying to focus back in about what brings you joy in your work. And so I'd love to hear from you all. Maybe Kristen, like, what brings you joy in work? What makes you get up early in the morning when it's snowing in February and it's dark out and say, like, I'm getting up today and I'm going in and I'm happy to do it?
Yeah, I think, for me as an OT, I help children be able to achieve goals that are important to either them, if they're of an age that they can articulate that, or or family goals. And so for me, being able to go in day to day and see kids make gains and, see the, light on families' faces when their child, puts on their shirt for the first time, or if it's a baby, their child rolls for the first time. And I think that, that has been a day in and day out, something that I find to be very rewarding about my job. I also get to work very closely with children and their families, and, develop nice, wonderful rapport with families. So that's also a really rewarding aspect of my job. And then also too, working at a teaching hospital, I have the opportunity of helping to advance students who are, so OT is a master's level, entry level field. So what that means is you have to do 2 years of academics for a master's, and then you do 6 months of clinical placements. And so we as OTs will train those clinical students so that they can sit for a board certification, which then allows them to be OTs. So that's another really rewarding aspect of my job, is being able to assist and train people who want to become OTs and are kind of on that journey.
So it's a lot about really seeing those kids make progress, those really how that improves the lives of them and their families, but then also sort of really passing on your knowledge to sort of the next generation of therapists. So thanks for sharing that. And Karen, I heard a little bit from you too about how you really work with teaching and teaching residents, teaching students, but you take care of really sick people. And I can imagine sometimes the outcomes are incredible, and sometimes there are some patients who don't always make it. But what sort of brings you joy in your work, and what makes you stick with what you're doing?
I think for me, there's no better feeling than walking through the transplant clinic and seeing a patient sitting in the waiting room that is like perfectly fine, and knowing that maybe 2 months ago, that person was on their deathbed and we didn't know if they were going to make it to transplant, and we were doing everything we could to try and help them. And just seeing that they were able to successfully get through that difficult time, and I was able to help them do that and then get to the other side. And now they have a full life ahead of them and like a fresh start. So that's really, honestly, for me, like what really keeps me going, because I am kind of responsible for coordinating all of the transplant testing and workup for every patient with liver failure in the hospital. And there's a lot of patients. And just like you said, a lot of them do not make it. Like, we do everything we can to help all of these people, but some of them are just so sick that they can't get to transplant. So even despite everything we try, so that is hard and it is sad, and we have to acknowledge that, as part of the work. But then it makes it even that much more rewarding when you are able to help someone and they're able to live a full life, or they bump into me in the hospital. I'm running around going to see my patients, and somebody bumps into me and they're like, "Hey, remember me? Like, I remember you. You took care of me when I was really, really sick, and now I have a new liver and a new life, and I'm doing great." And that's always really great to see, and it warms my heart. So that keeps me going.
Thanks for sharing that. And I can see how that would be so uplifting for all of you on the call. Really, these liver end-stage liver failure patients are the sickest of the sick. And if you saw one of them, you would say, there's no way that this person can make it through this illness. And so the ability to provide someone a transplant really is, it does seem like every time it's a miracle, because it just, when you see how sick these people are, you think there's just nothing that can bring them back from the brink of death. So I could see how even just like one patient, one day could be so motivating. So, and Beth, you told a really great story about sort of what sort of has driven you to where you are. But now, it sounds like you're doing a lot of administrative work, a lot of research, a lot of teaching, and not as much at the bedside. But what is it that brings you joy in what you do? You're still on mute.
I still hear from patients that I saw many, many years ago. And when I was doing clinical work and seeing patients myself, I would say the greatest privilege that I can imagine is doing genetic counseling for 3 generations of people within a family. And so obviously that's not too common, but in several instances, I've gotten to meet many people within a family, siblings or children. And then in a handful of families when I've tested a grandmother, a mother, and a daughter. And I think that, through seeing hundreds and hundreds of patients over the course of my career, no 2 genetic counseling sessions are alike, and no 2 people come to the table with the same expectations or even reactions to genetic testing. And the fact that so many people pursue genetic counseling and testing to feel, and this is a word that most patients use, to feel empowered, that they want to be able to take proactive steps to protect their health. What can they do for increased screening or for risk reduction to not develop some of the hereditary cancers that they've seen strike other members in their family? So I think that aspect of my career has been extremely gratifying. And here the other day, I heard from one of the first patients I saw when I came to Georgetown in the 1990s. And it was just extremely gratifying and moving to hear that. And likewise, I would say now that I do a lot more teaching, I think, and I tell my current students, like, if you really want to make my day down the road, keep in touch. And I love hearing, students will send me articles on genomics, or when they go on, many of them go on to be physicians or genetic counselors, actually. And they say, hey, I saw a case and I thought of something that we talked about in our class. And that just brings me a ton of joy. And I put all of those emails in a file to read when I'm not having such a great day.
That's an awesome strategy to sort of hold on to those like monuments of success that sometimes I think we don't take enough time to celebrate our good days and celebrate our successes and celebrate our wins. Yeah, because our lives are so quick.
Yeah. And I really view it as impacting people one at a time. Like if I thought about it, I'd say, well, these are, all the people I've counseled and all the people that I've taught. But what I really remember is the one-on-one. And, with patients that I've heard from, over time, one of the things that really strikes me that I would not have realized is patients have said, and I imagine that many of you on the panel have had this experience as well, and the moderators too. Patients remember the exact words that I used when I gave them a test result. And they remember the conversation around that. And so it's a good reminder to me to be thoughtful about the words that I choose and how I break news. So when I deliver a positive result or tell somebody that they have a mutation in a hereditary cancer gene, I don't deliver it by saying, well, I have bad news for you, because many times to the patient sitting next to me, that is not the worst news they can hear. Getting a cancer diagnosis or hearing that treatment has failed is perceived often as much harder news to digest. So I think that those are just very, personal and touching reminders of the importance of the little things that we do even.
Absolutely. And I think, when you're interacting with a patient, like they really do cling on to your every word, right? Every word means something to them. And so we do have to choose our words carefully because, patients will tell you, Dr. So-and-so said exactly this, or, well, I talked to the therapist today, or I talked to the nurse today, and she said, and they will say exactly what that person told them, because like, they're really like, people are trying to be empowered to take care of their own health and to really drive their own outcomes. And so they're listening to what you're saying. So I really appreciate that perspective. Keene, there's a great question in the chat from one of the students about what other areas of pharmacy have you encountered, and sort of how has it differed in the responsibilities in those sort of areas of pharmacy? You touched on what it was kind of like in the hospital, but what other sort of areas of pharmacy have you experienced, and what is that like?
Yeah, so in pharmacy school, you actually do rotations to kind of get a flavor of what life as a pharmacist would be like in different settings. So the traditional ones are, you can also work in the hospital, and you can also work outpatient, and then you can work in community pharmacy. So in community pharmacy, that's like working at a CVS or Walgreens. It's more of like a dispensing role. You check prescriptions and like make sure it gets filled correctly and like out on time, and counsel the patients on their medications, and also give vaccinations. And more people in the community setting are like, trying to do more clinical stuff. But, as you see on the news, that you just have like such high demand to like get out scripts that it's kind of hard. But there are some models that have been successful. In terms of like the outpatient, like more clinical setting, you have ambulatory care pharmacists. And what they do is they pretty much act as like a mid-level provider in the primary care setting. And they see patients with chronic disease states. So they see patients like on anticoagulation, like warfarin. They see patients that have diabetes, and they can even like write their own scripts write their own scripts, order lab tests, things like that. And just kind of comparing all three, like inpatient, you don't really have to deal with insurance. In ambulatory care setting and community setting, you have to deal with insurance, which can kind of be a pain. And I would like and then there's also like more like non-traditional routes, like working in a drug information center, working as a poison control center, or like even just like starting your own consulting services. I know that like some pharmacists have started consulting services with pharmacogenomics actually, and also medication therapy management.
Yeah. And I'm not lying when I say pharmacists are some of my favorite people. And I think what Keene was saying in some of his comments was super important. So when I was a resident in primary care at the Veterans Hospital in Michigan, I would send my patients to my clinic pharmacist, and she would actually essentially manage their diabetes. So she would try one medication that probably best fit the patient's profile, and would up titrate it, and would do phone call visits with the patient. And then if their labs weren't where we wanted them to be from a blood sugar standpoint, she would start another medication, and she would send me sort of communication in the patient's chart about how things were going, or if there were questions, or if I had comments about what she was recommending from the prescription standpoint. And so I think we're leveraging our pharmacists more and more for some of that chronic disease management, like diabetes and high blood pressure, especially in the outpatient spaces, because there's really good, our pharmacists are so knowledgeable about all the different medications and which one to start with that fits that patient's profile best. What do we go to next if that's not working? And really doing a lot of work with that chronic disease management. And then I also work very closely with one of our hospital pharmacists who really just specializes in infectious disease and doing quality improvement work around appropriate prescribing of antibiotics, so that we're not contributing to the problem of antibiotic resistance. So I feel like pharmacists can do so much and play so many roles. And then my brother is a pharmacist and works for CVS as a pharmacy manager. And so yet doing more of that sort of community setting. So I just feel like you guys are so multi-talented and are just an amazing part of the care team. So thanks for sharing your sort of your journey. I also saw there's a couple great questions in the chat, like as we were talking about burnout. We all like to share our joy in work and what really drives us, but like, what are the things that are really difficult? What are the things that you struggle with in your job? What are some of the things where you kind of get home at the end of the day and you're just like, oh man. I would say for physicians through COVID, we've had a lot of them. I think one of the big ones for us too, and you all in the healthcare setting are probably facing as well, is really those social determinants of health. Really saying, the patients, I have a patient in the bed and I really want to help them and I really need to get them this medication, or I really need to help them quit smoking. But just the situation that they're in is not setting them up for success to be a healthy person. They don't have transportation to their appointments, or they don't have insurance, or they can't afford their medications, and feeling like there's so many things out of my control that I want to change to help that patient. And I really think that healthcare we're slowly moving there. We're slowly moving towards what we sort of call like a value-based model of care for our patients, saying it doesn't make any sense, it's much more expensive for us to not pay for the patient's medications and have them show back up at the hospital in 2 days sicker than they were, than to just help them with whatever that barrier is in their life that's not letting them sort of take control of their health. So, but for me, that's one of the hardest things, is sometimes feeling sort of hopeless, not being able to really get the care, the right care to the right patient at the right time because of those sort of social determinants of health. And that can be really hard sometimes, but I want to kind of open it up to our panelists as well. What are the things that are just really hard some days that make you think twice? And I'm happy to call on someone. I know I've been kind of going through everybody sort of systematically, but Kristen, sort of what are some of the challenges that you faced in your role? I know I love kids because kids get better.
Yeah, I would say on average, that is pretty much, especially in an outpatient setting. It's a little different sometimes in an inpatient or an acute care pediatric setting, but in general, the patients that we see are prognostically, I do treat cancer, pediatric cancer patients, but for the most part, prognostically, they're kids that are going to, do well and live a full life. I think, to touch a lot on that, there are a lot of social determinants to what I do as well. Family dynamics, and I do treat a lot of kids who are within ACS, so that's social services, so who have been taken away from their parents. Transportation is a barrier, getting the children able to come to therapy. So those are definitely some barriers that impact a child's ability to even participate in an outpatient setting for occupational and physical therapy and speech therapy. One of the biggest ones that I think has kind of been touched on is insurance and financial aspects. Being able to complete the necessary paperwork, and we'd have to do a lot of justification as to why a child should be allowed to come for more sessions. We'll get a lot of, we'll approve 10 sessions and that's it. And it's like, no, but we need more. So I think that that's probably one of the biggest barriers to the success. I would also say just to kind of understand a little bit more of my day-to-day, outpatient is an extremely fast-paced setting for OT. And the beautiful thing about occupational therapy is you can be in a very fast-paced setting, you can be in a hospital-based setting, you can be in a school-based setting. And so you have a lot of flexibility with kind of where you want to go within the field of occupational therapy. And I'm just kind of this one little niche. But time is definitely a factor. So there are days where, our sessions are 30 minutes to 45 minutes in length, and we're back to back to back to back to back. So from that standpoint, I think that can also, affect. There are things that I would love to be able to do in my job that sometimes financially, time management wise, I just don't have the time to be able to do, such as, spending an additional 15 to 20 minutes with a family to go over a home exercise program or things like that. But that's pretty unique to outpatient and pediatrics, not necessarily occupational therapy as a whole.
That's awesome. Yeah. And I can see how some of, how that would be really difficult. I think we all, when you said insurance, we all went, the collective sigh together, because it can be really frustrating to feel like that's like the one barrier between getting what your patient needs. And then, days can just be really busy, and sometimes it's exhausting to have patient after patient after patient. And sometimes it is tiring, but fulfilling at the same time. So
exactly.
Karen, there's a lot of questions about PAs as well. I think a lot of people are interested in a couple things. One, what is your biggest challenge? What is, one of the things that is hard about your job? And then also, I think people are just very interested in general about like, what is sort of the breadth of the work of a PA in terms of like, how do you know what you want to go into? What can you go into? What does a surgical PA do? What is that like in the operating room for them? I think there's a lot of people who are interested in being PAs, but don't really know one or haven't been exposed to like what that career trajectory looks like. So if you could share a little bit about like what's challenging about your job, and then sort of if you know anything about like what a surgical PA does or what that training looks like, I think there's some interest there too.
There are a lot of things that are challenging about my job. Sometimes I go an entire day without sitting down, and maybe I drank some water, maybe I ate something. Like, I'm just so busy and running around and trying to be in 20 different places at once. And sometimes everybody needs something from you. And that's hard. But it can be with any career in medicine, especially if you're in an inpatient setting and it's fast paced and you have high acuity and a lot of patients. Again, just to kind of touch on what you guys had already discussed, a lot of the social determinants of health can be very challenging. And then one of the other things can be having to deliver bad news to patients and their families, which unfortunately is part of the job. And there really is an art to it. It's not easy to do, and it never feels good to have to tell someone or their family that they're too sick and they're not going to make it a transplant or something like that. So that is another challenge, that I face. But in the end, obviously, the benefits of my job and the rewards, certainly still outweigh all of those things. And that's what keeps me going. PAs work in every specialty you can imagine, everything from like primary care, where they're in a clinic seeing patients, under the supervision of a physician, but generally seeing patients independently, to surgery, to OBGYN, plastics. I mean, you name it, any specialty you can think of, inpatient, outpatient, there's probably a PA or nurse practitioner somewhere doing that. My advice would be, if it's something that you're interested in, I would highly encourage you to shadow some PAs, and shadow some doctors to kind of get a feel for the differences between the two. For me, being a PA really was a quality of life decision, like in terms of my work-life balance and my hours and the amount of, time just, being in school, and in terms of the educational component there. But there are PAs that do everything. So I would say, don't just shadow one PA in one field, shadow PAs that do everything. And any of you are welcome to shadow me at some point if you're interested. I know during COVID, there had been like a lot of restrictions, but I think they're sort of starting to lift some of those. So I don't know yet if we can have students shadow us, but hopefully at some point in the future, if any of you are interested, I'd be happy to have you. And you can certainly shadow other people as well, because everybody's day is going to look different depending on what they do and what area they work in. And when you're in school to become a physician assistant, you rotate through every specialty. So you do 8 weeks or 12 weeks in each setting: primary care, inpatient, outpatient, surgery, this, that, and then various electives as well. So that way you get a feel for the whole spectrum and you can decide what you like or what you're interested in. But again, because I'm not like a physician that's completing a full residency in that particular area, I have kind of a general background. I have the ability to kind of flip between different specialties and learn on the job. So that's another part of the beauty of being a PA, is just that you can choose between so many different things. I'm just looking to see what other questions, does that kind of cover it? Or are there other questions?
Yeah, I think that's a great summary. And in hospital medicine, even, so we have PAs that work with us as well, that do all sorts of different things. Like you said, I mean, we admit all adult patients into the hospital, and many of our PAs, they either they do admissions, and admit our adult patients to our hospitals, 24/7, 365. They, they do consults for our surgical teams. And we have PAs on our gastroenterology service, on our general surgery service, on our bariatric surgery service. Our PAs, work in the primary care clinic. So I would say in terms, and it sounds like you agree, Karen, in terms of like the PA role, it really, you can be in any part of medicine that you want to be. It's more understanding sort of how a PA interacts with the care team and if that's really right for you in that role. So, yeah, I would agree. There's sort of a crucial part of our team within the inpatient and outpatient spaces. So thanks for sharing that. And Beth, what advice would you have for students looking to gain exposure to your career path? I think you are, so specialized in what you do, and many people may never run into a genetic counselor who has your sort of background and experience. And if someone was interested in what you do, what advice would you give to us?
So thanks for the question. I think actually, like others have said, I would say to consider other careers that may check the boxes. So a lot of people say they want to be a genetic counselor because, not unlike me, they like the science and they like working with patients, and everybody on this panel does that as well. So I would say, take some time to think about whether there's something about genetics in particular that interests you, and what aspect of genetic counseling and what other fields could check the box. And then to really expose yourself, like Karen said, shadow a genetic counselor, learn about the profession. There are websites and organizations, the National Society of Genetic Counselors, American or the Accreditation Council for Genetic Counseling, the American Board of Genetic Counseling, which has a lot of information about the profession and videos and things like that. It is a very popular profession. But there are only very few genetic counselors, 5,700 in the country. So that's only about 7 genetic counselors per 500,000 people in the population. And as you know, more and more people are getting genomic testing, are being, clinically being advised to consider genomic testing. And it's probably only a matter of time before everybody can get their exome or their genome analyzed. So the demand is going up. There are only right now 52 training programs in the United States, and they tend to be small. So the programs are very competitive to get into. And I think one of the things that the schools are looking for, it's now, I would say, not as common as it once was to accept students right out of undergrad. They want to see that people have taken some time to research the field, have immersed, and have decided okay, I don't want to be a physician or PA or nurse. I want to be a genetic counselor, and I've had exposure to the profession because the attrition rate is high. And there are not that many training slots. So I think the more exposure that people can have beforehand, the better.
That's fascinating. Why do you think the attrition is high?
I think there are several reasons. One is burnout. The second is salary. Salary has typically been low, but it's getting much, much better in the last few years. It does tend to be a profession dominated by females, which has been a problem it's been an issue that the professional societies have tried to address to recruit and attract more males and non-binary individuals and more diverse people in general from different race and ethnic groups as well. So I think that I think those two issues have been a factor, and but I think the situation is improving as salaries have gotten better because, again, there's have been statistics that there are hundreds of positions per graduate, which is just startling to me. And so I think that facilities, hospitals, private offices are recognizing that if you want to hire a genetic counselor, you have to prepare a competitive package. And so the salaries are getting better, and career advancement has improved as well. But relatively speaking, it's a fairly young profession. And so thankfully, I think it is evolving.
That's really great. and helpful background. I think that'll be really helpful for students to know, just because it is such a, again, you've mentioned it's competitive, but it's also a very unique career. So I don't think, like you said, there's not many of you, and you probably won't run into someone who has your skill set on the street every day. I think there's not as much access to being able to find someone with your skill set to shadow or ask questions to. So we have about 5 minutes left. I do want to take one last question and sort of open it up to all of you. I think there's a lot of perceptions and interests about sort of work-life balance in medical fields. And I think, Karen, you even brought it up, and it was brought up by someone else as well, how many years people want to commit to training, thinking about if people want to have a family or what their work-life balance will look like. Do you all feel that you've sort of achieved the work-life balance that you've wanted? And in your career, in your field, and what are your thoughts and perceptions and reflections on that in what you do?
Yeah, I can take that. So yeah, early in my career, I felt like I didn't have that balance, and I got burnt out, and I was like, wait a minute, like, I don't want to feel like this. What can I do? So, because when I was like, why am I burning out? Like, in the healthcare profession, you're often asked to work more than like 40 hours per week. And I was like really glad to do it. Like, I really wanted to take care of my patients. Like, I would be there like 60, 70 hours a week, even though like my job only required that. Cause I really wanted my patients to get the meds and really just be taken care of. But as we get like more knowledge in healthcare about burnout, you really just have to like take care of yourself. And when I started focusing on that and like leaving on time, even though I felt guilty about not helping patients, I actually provided better care, provided better interactions. I was more efficient. And then, so yeah, really just taking care of yourself. And then also like, you also have to just like deal with politics. You kind of just have to like be observant and just like really be patient. And sometimes you have to say like, hey, this system is like not, this healthcare system, this facility is not meeting my needs. You might have to make other moves. So like, there's also just kind of like you have to like really have like that emotional intelligence, that skill set to just really like find that balance. And it's like easier said than done when you're entering the profession, with like a servant like mentality.
Thanks for that. I think that's really helpful to be always sort of reflecting on where you're at, and you can really only provide the best care for your patients if you're taking care of yourself first, most certainly. Any other thoughts before we sort of wrap up on work-life balance? I have a lot of thoughts on work-life balance. Let me tell you about residency and medical school. And, just briefly, I will let the students know that, yes, becoming a physician is challenging, just like with any other health profession. Becoming a health professional is challenging and it is taxing, but you can find that balance. I got married in medical school. I had my first kid between my third and fourth year of medical school, and I had my second kid at the end of my intern year in residency. And it is possible, to find that balance in what you're looking for. It really it all depends on having those people and programs to support you. So really choosing programs that in whatever profession you go into that are going to support your needs. So I was really lucky in finding a medical school and finding a residency program that was going to sort of welcome me as someone who wanted to have a family, was going to really work with me around what my clinic schedule was going to be when about taking a year off between my third and fourth year and coming back and then applying, for residency at the end of medical school, and really working to make sure that I could be successful in that way and sort of balance my family. And it really, if I could go back, I wouldn't do it any other way. It really helped me mold my career around my family, rather than having my family sort of molded around what my career trajectory was. And so it's not impossible. It's certainly difficult. I think it's a challenge that we all face sort of in the workplace, in whatever field you choose. But I think more than ever, it's just really about finding the places that you're going to train, that you're going to work, that fit what's important to you. But I think it is all possible.